Okay, please move along to your seats. We'll start in just about a minute. Okay, just a quick reminder about the afternoon schedule. So in just a moment, Dr. Wigley will tell you his approaches to difficult scleroderma problems. So that should be terrific. Then right after that, we will have a short break, 15 minutes, and then we'll come back. Dr. Ercan will give his second talk of the day, which should be really exciting, taking on challenging treatment of APS problems. And then we'll go right into the panel, starting at 4 o'clock, really right on the nose. Dr. Ercan might have to leave about 4:30 to get to his flight. But the panel will consist of Fred and Doric and Joe McCune. So feel free to bring up more questions and put them in the basket here. Okay, so it's my pleasure to reintroduce Fred Wigley, who has the sort of redundant title of difficult scleroderma problems, because I think they're all difficult, but there's no one better than Fred to tell us his approach. Thank you.
And I was going to say that every patient with scleroderma is difficult, so it's easy to pick out cases. So my goal is to talk about some common issues that I'm often asked about, and also then to bring you up to date on some of the new exciting things that are happening for difficult patients. These are my disclosures again. The first case that I wanted to talk about was one of the things that is often forgotten by the physician, but is actually one of the number one complaints that patients have, and that is the cosmetic effect of this disease. And in particular, this furring or linear lines that are around the mouth associated with thinning of the lip and a decreased oral aperture. This not only bothersome from a cosmetic standpoint, but it also affects oral function and the ability to take care of one's teeth. And unfortunately, there's a very significant problem with the teeth in patients with scleroderma that's very common, with regression of gum, loosening of the ligamentous structures, and loosening of teeth and loss of teeth that are a consequence. And so it's very important that your patients get good dental care. So what's now being done is to use transfer of fat that is autologous from the patient's own fat deposits, and to inject them in tiny amounts along these vertical lines. And there was a just published study of 62 patients done in the UK where they showed that there was benefit not only in the sense of well-being from the patient, but also function of the mouth. We've done about 10 patients with good success. And all the measures of mouth function and levels of anxiety, depression, for example, improved in this patient group. We also, just to show you some of the pictures that they have, you can see in this, the upper panels are the before and the lower panels the after, and it can be quite dramatic. My plastic surgeon says it's actually not just the fat which is delivering stem cells, which is something they've used, by the way, for a long time in burn patients and trauma to the face. The fat stays there forever, goes up and down with weight loss and gain. But it's also, when they do the needle into those lines, they're actually disrupt some of the fibrosis that is under the skin. Another trial has been done in the same fashion of using autologous fat to inject it into the base of the finger to see whether these stem cells could prevent progression of contractures and loss of function of the hand. And this has been done and published in open trials in Europe. A controlled trial done in the United States did not show a benefit, probably, again, because of the issue of timing of when actually a stem cell would have the capacity to help versus a late-stage contracture which wouldn't respond. But the injections along the base of the fingers have been published. So you're going to be hearing more about using fat as a source of stem cells to see if you can help tissue repair. I would remind everybody that your patients with scleroderma, when their arms are getting fibrotic, one of the things that you'll see is a loss of fat. And when they recover, fat recovers and hair growth comes back. So those are clinical signs of disease control. So the second major problem that I get asked about all the time is, what do I do about dystrophic calcification or calcinosis, which is all too common in our patient population. The etiology of this is totally unknown. There's lots of theories about upregulation of calcium binding proteins, the lack of inhibitors of like pyrophosphates that inhibit calcium deposits. These things are all a theory and not well known. The one new theory is that when there's injury to skin or injury to tissue, there are stem cells that go to those areas for repair, and they can transform into osteoblasts and be bone-forming cells that are in injured tissue. And of course, it's not just limited to scleroderma. Calcinosis can be quite problematic. A patient of mine sent me some of the calcium that had clustered out of the skin. This is calcium hydroxyapatite, the same thing that your bone is made out of. And the many different avenues of treatment have been tried, and they've all been generally failed. Low-dose warfarin is not helpful. There's some evidence that TNF inhibitors may help in patients that have dermatomyositis. We've not seen that in scleroderma. Bisphosphonates have been used. Again, there's a lack of good evidence that they're helpful. The one thing that sort of went through a wave of enthusiasm was the use of thiosulfate, because infusions of thiosulfate had helped calciphylaxis in patients with renal failure. In those patients, they have a calcium phosphate imbalance, and thiosulfate infusion had been quite dramatic in helping the calcification of blood vessels. But in scleroderma and in other dystrophic calcification, it's been disappointing. You'll see reports, however, of cases where they rubbed thiosulfate over the surface and they injected thiosulfate into the wound where there's calcium, and the calcium resolved. These are case reports. I just make you aware of them, but there's no good solid evidence. I must say that the JAK inhibitor is interesting. I have a patient right now who on a JAK inhibitor, her calcium is getting better. So we'll hear about these cases. And there was a case report reported just as I was thinking, oh, I'm going to see what happens to my patient and quantify it. And that patient also had improvement with a JAK inhibitor. There are a lot of interesting cases now with rituximab that seems to be helping everything, but nothing has been solid. The one thing that is clear, that prevention of disease activity and prevention of injury to the tissue is the one thing that can help calcinosis. And calcinosis can resolve, particularly if you are able to control the underlying disease process. Most of our cases have been limited to extraction of the calcium in areas that are problematic. There's this interesting survey that was done. If you took over 1,000 patients with scleroderma, about 23% of those patients developed calcinosis. And then in serial studies looking at patients that did not have calcinosis, even another 20% of those developed it over time. But those individuals that were on a calcium channel blocker to treat their Raynaud's are less likely to get calcinosis of the fingers than those that were not treated. So preventing the injury as best we can is the best treatment for calcinosis at this time. I point out this patient of mine that was quite problematic in that she had calcinosis in multiple areas of the body, and they were associated with inflammatory episodes of fever, malaise and chills, to the point that people thought that she had sepsis from this. And they really were crystalline events from this hydroxyapatite material leading to inflammatory spells. And she did not respond to even low doses of steroids, methotrexate, non-steroidal anti-inflammatories. She continued to be quite ill with these very inflammatory episodes. And so I ended up putting her on anakinra, very much like we do with tophaceous gout in complicated cases. And in fact, she had a remarkable improvement with a lack of these febrile illnesses and these episodes of crystal-like events. And these events were clearly fluid associated events that were helped. Not only that, by the way, her sedimentation rate, which was in the 60-70 range, fell to normal, and she felt better all over, and her scleroderma has been in a quiet state, so maybe this inflammasome pathway is playing some more systemic role. Ultimately, we had to debulk this kind of lesion by surgical excision and then keep the anakinra to keep inflammatory episodes from occurring. She did not get a total meltdown of calcium deposits, but the inflammatory episodes stopped. She is an interesting case in that she had mediastinal calcification as well that actually was obstructing her vital organs, and so we had to do a surgical resection and drainage of that area. And with the anakinra, she's not had any recurrence of this mediastinal calcification. The calcification can occur in just any site in these patients. So my next case is a 56-year-old gentleman who is topo positive, complicated course with GERD, sclerodactyly, mild interstitial lung disease, and a history of Raynaud's. And this is a picture that actually the patient sent me saying, I've seen you publish some pictures of Raynaud's and you really don't have a good picture. This is a dynamite picture. She was treated with myclophenolate and things were stable, but then he developed a digital ulcer. And so the question is what do we do for patients who present with recurrent digital ulcers, a major problem in our population. Now remember, scleroderma, there are a variety of things that happen in the fingers. First, many patients will have Raynaud's alone and never get a digital ulcer. And although the Raynaud's episodes are uncomfortable, they're not threatening the finger or causing ischemia. The second thing, of course, is you get these ischemic ulcers that are on the tip of the finger, and those are the typical vascular occlusion episodes that are due to the peripheral vascular disease. But you can also get these things like that other picture of the shaft of the finger where the finger just sort of erodes, and that's because of scleroderma affecting the small vessels that are in the skin, and that's much more problematic and less likely to respond to vasoactive agents alone. And then there's a subset of patients that get macrovascular disease, and these are patients, by the way, that have less skin, and that macrovascular disease associates with the anti-centromere antibody profile. Then the other type of ulcer we get are these traumatic ulcers over the PIP joints that can get deep and cause significant trouble. And this is because of thinning of the skin over the PIP joint, and they're not the kind of a lesion that absolutely respond to vasoactive agents like the vascular lesions on the tips of the fingers. And then there's a variety of digital lesions that we could spend another hour talking about that are often confused. I can tell you, have an ulcer that's not healing on the tip of the finger, look for underlying calcinosis because calcium buried in an ulcer can keep it from healing. Usually these ulcers with loving care get better within a 6 to 8 week period. All digital ulcers are all too common. They're seen in about 50 to 60% of our patients. And there are patients that are at higher risk for getting digital ulcers, particularly if they have nail fold capillary abnormalities and a higher level of sclerotic skin and the presence of anti-topoisomerase. The vascular disease in scleroderma is not a vasculitis or inflammatory disease. It's a vasculopathy. And it's caused by this thickening of the intimal layer, and then associated with that, hyperactivity of the musculature so that you get vasospasm on top of a small lumen, and then you get occlusion. You can see this same type of vascular disease wherever you look for it, in the lung, in the kidney, in the skin. And you can see that occasionally these are macrovascular occlusive events. If you do an angiogram, that will shock you, despite the fact that the patient may never have a lesion. the vascular are involving substantial blood vessels and can lead to, of course, these macrovascular events instead of these tiny digital ulcers. Now, if we start the movie on the one side, you can see that a patient comes in with a blue hand. You say, oh my God, is this going to lead to ischemia? And one way you can tell is by simply pushing on the tip of the finger, and you see that nice response. Those patients are not in an ischemic event. On the other hand, if you start the movie on the other side, this is a patient who presents with a blue finger. Start the movie on the other side if you can. There we go. See the sluggish flow. By the way, if you look at my fingernail, you can see this got vertical lines in it. That's called a senile nail. I've been depressed ever since I found that out. Those patients that have that sluggish flow can lead to this type of a lesion that certainly mimics a vasculitic kind of lesion. And I just wanted to point out that a lesion that's progressing will have this little, see that red line right behind the blue line? That means that the finger is still ischemic, and if you sit on it, it will march down the finger and the patient may lose a significant amount of digit. So this is where you need to react and take action. On the other hand, once a finger is totally infarcted, then the erythema will disappear, and the patient sometimes will come in and they'll thump their finger on the desk because it doesn't hurt anymore. But if you see that erythema, that's trouble. Once the erythema is gone, it's a done deal. You have a finished infarct and a different management. Now you're talking about allowing the finger to self-amputate or surgical procedure. The one thing that is key is pain. Patients that have pain have continued ischemia, and you need to pay attention, along with that erythema, even if it's a small streak of erythema. These are clinical clues. So what do we do when you have an acute ischemic finger? The first thing is to stop the patient early on and say, go home, get into bed, pull the cover up to your neck, stop working, stop the trauma to your finger, and that can make a huge difference. I will often do a digital block if the patient has a lot of pain with lidocaine. You just swab up the web of the finger and numb up the finger, and you can sometimes block an event, and it certainly helps with pain. If you hit a blood vessel, just send it for blood gas. And if the patient looks very acute, then we will admit the patient in order to do this therapy. And whether you anticoagulate or not is a debate. I often will if I have a catastrophic-like event happening for a transient period of time. Long-term anticoagulation in the absence of a hypercoagulable state is not indicated. Antiplatelet therapy has not been proven to be helpful, but it makes sense for some period of time because there is a thrombotic event occurring in these patients. In terms of medical therapy, I start a vasodilator. If they're not on a calcium channel blocker, I start a short-acting calcium channel blocker in the hospital to get loaded, and then we move to a long-acting agent. And before combining medicines, I maximize the dose of the calcium channel blocker to what they'll tolerate. If they've been on a calcium channel blocker, then I'm talking about combination therapy, and you can choose either a nitrate if it's a single finger or a phosphodiesterase inhibitor if it's more complicated, because I think nitrates are difficult to handle long term. And I wouldn't use both of those because they can lower the blood pressure too much together. For those people that are not responding to warmth and these vasodilation therapies, then we use prostaglandins. And we use isoprostanol used through a peripheral vein infusion, usually putting the patient in. We can do it as an outpatient, but you can do it in the hospital. The prostaglandins are given as a low dose, slowly titrated up to tolerate it to 2 nanograms per kilogram per millimeter, and then watch them for a 3 to 5 day period of that infusion. And we have shown in a clinical trial that type of therapy will reduce Raynaud's events for some 12 weeks or so after the infusion, but in an acute situation may reverse the event very quickly. But what do we do besides trying to stop the vasospastic event? with vasodilation therapy. We really should be talking about what can we do for the vasculopathy itself, which is the underlying pathology. And we really tend to ignore this. It's not an inflammatory disease where steroids work or Cytoxan works. And so we're talking about drugs that help blood vessels. And the number one on this list are prostaglandins. And our European friends for years have been using intermittent dosing of iloprost in patients that have recurrent digital ulcers. And the protocol for that is all over the place, but you can give it once a month, once every 3 months, an infusion therapy that can last for 3 days as an outpatient or 5 days, depending on what you're capable of doing. But prostaglandins are not only vasoactive agents, they also protect the endothelial layer and have some impact on the pathogenesis of this disease. The other agent on this list that has shown benefit is the endothelin inhibitor bosentan, which has been approved in Europe for the treatment of recurrent digital ulcers in patients with scleroderma. In fact, the two main advances in the last 10 years in treating peripheral vascular disease and scleroderma is the use of bosentan in patients that have recurrent digital ulcers in scleroderma, and the presence of using the phosphodiesterase inhibitor in addition to calcium channel blocker or instead of it. In my experience, combining the phosphodiesterase inhibitor with the calcium channel blocker is our best treatment in practical treatment for these patients. Bosentan is now licensed to prevent digital ulcers with scleroderma. Two different multi-centered clinical trials have shown that it decreases the evolution of new ulcers compared to placebo. It, however, did not improve healing of present ulcers, and importantly, did not decrease the frequency or duration of Raynaud's phenomena. So it has something to do with the fibrotic process and the endothelial protection that it gives, but it's not a vasoactive agent. I have to tell you that the other Macitentan does not work in the clinical trial that was done, so only the bosentan is the one that has been shown in clinical trials. The phosphodiesterase inhibitors have also been shown to have benefit in, I'm only showing this one trial that was a 12-week trial where they used the sildenafil at 20 milligrams 3 times a day versus placebo. And what they found is that it did not reach their primary goal, which was the time to healing, but it did reduce the number of ulcers compared to placebo. And these are the kinds of pictures that they showed where the ulcers were present. They had to be present in order to get into the trial, and they healed over some period of time. And what they showed is that the group that was on sildenafil had a decrease in the number of digital ulcers at 8 weeks and 12 weeks of trial. Again, another trial that showed some benefit of phosphodiesterase inhibitors in these patients. Botox has become popular for a variety of things, from migraine headaches to wrinkles in your face, and so why not try it for Raynaud's and scleroderma? And there's been many open-label trials suggesting that it's beneficial, but as we heard earlier, there can be a placebo effect in any clinical trial that we do. And in fact, in Raynaud's trials, the placebo effect is up to 40% improvement. So what we did is we did a trial where we had a randomized double-blind placebo-controlled trial where we gave the Botoxin to 40 patients with scleroderma, and we injected one hand with the Botox and the other hand with saline, and neither I or the patients knew which hand was which. And then we looked at blood flow, and we looked at clinical parameters, and we didn't see any difference in those population. Now, there was some suggestion of patients who were on calcium channel blockers at the same time had a little bit more benefit than those were not. So there may be, and these were not patients in a critical event. The hand surgeons are still using Botox in patients with critical ischemic events, but it was disappointing. And it's costly. It costs about $1,000 to get an injection therapy like that, and if it's not going to work, I've not been using it. There is, however, as I mentioned, a consensus now around the world in the scleroderma world of using intravenous prostaglandins In Europe, they use a product called Ilapros. In this country, it's isopropanol or Flolan that's available. And we use their other, there's treprostinil, there's isopropanol, there's PGE1, but the PGI2 or prostacyclin is the most potent agent. And the protocol is usually to give it at 2 nanograms per kilogram per minute in a continuous flow through a peripheral vein. And we do it for a 3-day period. Others have done it for 5 days period. We do it as an outpatient in the infusion center. And these are tiny doses compared to those doses that you use for pulmonary hypertension. There has been disappointment in oral prostaglandins in terms of the clinical trials. There's an oral treprostinil that is available. And in the trial that they did, there was the idea was to do the same thing that they did in bosentan, which was to decrease the presence of new ulcers. And they did not reach that goal. However, when we did an analysis of the study afterwards, there were patients that went into the OPAL labeled part of the study, the long-term use of the treprostinil outside of the shorter-term controlled trial component. And those patients had a good control of ulcers and a lack of new ulcerations. And then when the trial was stopped and they took all the drugs away from the patients, there was a rebound of new ulcerations in those patients. And so Amy Shaw published this to show that there was some suggestion that oral treprostinil used in long term may have some benefit. And I must say that given the benefit of prostaglandins, that I will try to get oral prostacyclin in patients that have problematic digital ulcers who are failing calcium channel blocker and phosphodiesterase inhibitors alone, and who I can't get the IV set up. And I've been able to successfully get the support for some of these patients. So oral prostaglandins are available. They actually get effective blood levels. As you know, they're on the market for pulmonary hypertension and should have some benefit. So for scleroderma digital ulcers or severe digital ischemic, start medical therapy if they're not on it. Calcium channel blockers. Some are using ARBs or fluoxetine. There's a small trial showing that they are beneficial, similar to calcium channel blockers, but in my mind, they're not quite as potent. If they don't respond to the calcium channel blocker, then I add a phosphodiesterase inhibitor and titrate up to the tolerated dose. Nitrates can be used as an alternative. And for those that are not responding, then we go to IV therapy with prostanoids as I've discussed. So this is a case. He's a 50-year-old gentleman. He has very rapid skin involvement with Raynaud's, shortness of breath associated with it, and he's anti-topo positive. Remember that we talked about in the first talk that there are biomarkers that predict the course of events, and this patient has antibodies to topo, which would predict that he would have lung involvement, and more importantly, would predict that it may progress. When we saw him on 2012, his vital capacity was 3.69 with a predicted of 5 liters. His echo was normal, and the CT scan, as you can see, showed some ground glass-like changes and some very mild areas of fibrosis. Now remember that the course of lung disease is highly variable, as I showed earlier. The most reliable tube to monitor the lung is a forced vital capacity that you can do in sequence. The total lung capacity tends to jump around, so the forced vital capacity is the best. And the diffusion capacity can also fall, but it too is more noisy than the vital capacity. The most rapid decline in the forced vital capacity is thought to occur in the first initial 3 to 5 years of disease, but progression can occur later. And in fact, in the clinical trials, they almost limit patients to those that have early disease and don't take patients after 5 years or so. The most positive topo, but also anti-U3-RNP or antibodies to THTO have also been associated with interstitial lung disease. The higher the risk in patients with severe interstitial lung disease is seen in those with diffuse skin disease as well. Note that a change of 10% in a 4 to 6 month period is consistent with active disease and progression. Many patients are being started just because they have findings, but they don't have any evidence that the disease actually is progressing. And as I showed you on the previous talk, when we look at our subsets, there are individuals that don't progress over time. One of the things that we're now appreciating is that the CT scan may be more sensitive than lung function tests to picking up early disease. That you can see ground glass-like changes, like in the lower slide, prior to the changes in lung function test. And it may be more sensitive to diagnose the lung disease, but it may not be as sensitive to follow people sequentially. In patients that have evidence of 70% drop in their vital capacity, or more than 20% of changes on the lung, ground glass-like changes or fibrosis, those are patients that are at high risk for progression of disease. And certainly if you see a CT scan with a heavy burden of changes, those are patients that you want to be aggressive with in treatment. You're going to be seeing in the near future studies like this using high-tech technology to look at disease activity. And you can see in these panels where you go left to right, where disease activity was reduced with therapy, and actually can quantitate with computer technology. These things are for us to be using in the near future. A randomized trial comparing 1 year of oral daily Cytoxan versus placebo showed that there was a modest benefit of Cytoxan over placebo. And the data showed it was about 2% of improvement after 1 year of Cytoxan. Now this trial, after 1 year, the Cytoxan was discontinued, and the patients were followed for an additional year. And that second year of follow-up, the improvement disappeared. So that short-term 1 year of Cytoxan was beneficial, but not lasting. And because of that, and the side effects and issues of long-term Cytoxan, a second trial was done comparing myclophenolate to Cytoxan, and there was equivalence with less toxicity with the myclophenolate group and the same benefit. The difference in this study, I should point out, is that again, the Cytoxan people were treated for 1 year and stopped, and the myclophenolate people were continued on full dose of 1,500 milligrams BID. And so myclophenolate now has become sort of the go-to medication as a first treatment in interstitial lung disease and scleroderma. So my gentleman came in. I can just see the numbers over there. You can see that he was started on cyclophosphamide because he was in the SLS study. And on the cyclophosphamide arm of the study, his lung function test improved. And then after some period of time, we put him on maintenance myclophenolate when we realized that it was as good and we didn't want to use long-term cyclophosphamide. However, now look at the date. This is now, he was seen in 2013, now it's 2017, and his lung function test began to decline. He had stopped the myclophenolate because he was in a remission. Both his skin and his lung were stable for that long period of time. You can see the data, 4.35, 4.68, and then he started to decline gradually. And then we looked, he not only had a flare in his lung that we could see, and you can see the changes in his CT scan, but he also had a flare in his skin at the same time off of myclophenolate. So I started him on a myclophenolate again. We had to, because of insurance issues, we had to use a short course of Cytoxan, which had worked for him before, but ended up on myclophenolate again. And despite that, despite his stabilization earlier, his lung function test continued to decline. So you can see it dropped from 2.37 to 3.0 to 2.75 liters on myclophenolate. And so now the question is what do we do in a patient that's failing myclophenolate, who's failed Cytoxan, and what are our options? And the options are azathioprine, IL-6 inhibition, Rituxan, and of course the new trials that are coming out with antifibrotic agents, pirfenidone or nintedanib. This data on rituximab is all open label, but a lot of studies that have been done in Europe looking at their cohort of patients. They usually use 2 infusions, and the data is short-term follow-up, as you see on this slide. And what they showed is that Rituxan stabilized or improved lung function test in this cohort of patients. So it became a reasonable option in patients who were resistant to myclophenolate therapy, such as my patient. There was, however, a large survey where they looked at, and again, this was a survey of patients who were treated with Rituxan and those that were not treated with Rituxan. And you can see that in both groups, there was a decline in skin score over time, but there was no real difference in the lung function test over time. And there was patients that were, however, treated with Rituxan with myclophenolate tend to have a better outcome than those that were just on Rituxan alone in this survey. This study was one of the only controlled trials in a very small population of patients where they compared cyclophosphamide to Rituxan. And again, this is this monthly regimen that they've used in Europe. And what they found is that there was an improvement in the Rituxan group, but not in the Cytoxan group in terms of looking at vital capacity over this 6-month follow-up period. And so a small study, small follow-up, but evidence again that rituximab may be helpful in scleroderma lung disease. And so that's what we did in our patient. Given the fact that he had failed, we decided to use Rituxan. And what happened is he had a dramatic improvement. In fact, his vital capacity did better than I imagined. It went from from 2.75 liters to 3.56 liters, and his skin also improved dramatically. So he went into a remission, and this is where we are right now. I haven't done yet the follow-up to see how long this will be in terms of duration. But it is an option to consider in patients who are failing myclophenolate. The new guy on the scene are drugs that are not immunosuppressive, but potentially have some effect on the fibrotic pathway, because we know that in the lung there's an upregulation of fibroblastic cells that are secreting collagen and causing the scarring reaction. The 2 drugs are pirfenidone and nintedanib. And nintedanib has, as you know, just been approved by the FDA for the treatment of scleroderma lung disease based on the study I'm going to show you. But I wanted to point out that both of these drugs have significant GI side effects. And of course, our patients, as we talked about earlier, the gastrointestinal problems are prominent in our patient group, so this is an issue. In fact, in the study, there was 75% of the patients on nintedanib developed diarrhea compared to about 30-40% in the placebo group. The problematic diarrhea was in the 40% of this group of patients. So this is the clinical trial that they showed. Those blue bars, the patients that the dark blue bar are the patients that are on the nintedanib, and the blue bar, the light blue bar, is the placebo group. And they had an advantage of losing less lung function over time in the range of 41 ml per year, which is a tiny amount. Equivalent about to the same thing as a Cytoxan recovery of around 2% of improvement. And the argument is that while it's a tiny amount, if it's sustained, 40 ml a year, year after year, would be a significant impact on the progression of this disease, and we would be happy with that. So there was a sub-analysis which I thought was very important, in that in this trial, patients were allowed to stay on myclophenolate if they had been on a stable dose 6 months prior to the trial. And the individuals that were on the placebo alone lost about 119 ml per year. Those that were on the nintedanib, as I showed you, they lost about 40 ml less. Those that were on myclophenolate did better than placebo, as expected, 66 ml per year. while those that were on a combination of nintedanib plus mycophenolate had even a better outcome, losing only 40 ml. So one could consider there's a signal that might be saying that the combination of an immunosuppressive therapy with an antifibrotic agent may be what we should do. The question is, how long will this be sustained? How long should we start it? Should we start it at the beginning, like when I saw this patient years ago, or not? The other lesson that I want to bring out, I forgot to mention, remember that everybody tells you that the scleroderma lung disease happens in the first 3 to 5 years. That gentleman that I told you who flared was years away from 5 years and still had a flare. So don't fall asleep with your patients that you're following in long term, that the lung can still progress. The pace of the fall of the lung changes with time. So this is a patient of mine that I wanted to point out just because I think that we're all excited about the nintedanib study and now have an alternative that makes sense, and I'm sure that the world is going to jump on using this medication. This is a patient of mine, a 45-year-old woman, topo positive, abnormal scan, started on mycophenolate. Lung function test improved from 2013 to 2015, and then she started having a decline. And she entered into the nintedanib study while on mycophenolate, and unfortunately was on the placebo arm. And on the placebo arm, as you noted, that she had a decline in her lung function, but she wanted to stay in, and she was on mycophenolate. Then, after the study, she moved into the open-labeled part of the study and actually got the drug, and her lung function test stabilized for some period of time. But she developed problematic diarrhea. And the way you treat that is there's two ways to do it. You can either start slow and go up, or you can start at the full dose and go down if they get the diarrhea, and use Lomodium with it. And we did that with her, and on the low dose, her lung function declined. And so now I'm stuck in someone who's failing this new agent, also on mycophenolate, and my drug to go to in her will be rituximab, and see whether that's helpful. So in a patient that has abnormal vital capacity or diffusive capacity, abnormal high-resolution CT scan with significant fibrosis treatment, and our treatment is mycophenolate 1,500 BID. And the question is, should we be combining that with an antifibrotic up front? We don't know as of yet. Remember that this clinical trial that was done was a very selective group of patients and does not necessarily mean that all the patients that we see should be treated in the same way. Now, if you have a patient with an isolated decline in the diffusing capacity disproportionate to the vital capacity, you should be thinking of pulmonary vascular disease. In scleroderma, if you look at scleroderma compared to other interstitial diseases, the diffusing capacity is always lower in the scleroderma population proportional to the vital capacity, and that's because of pulmonary vascular disease. And in those patients, you should be thinking of the evolution of pulmonary hypertension. And so I want to just tell you about this patient and ask how you would handle them. So this is a 70-year-old woman who comes in complaining of a sense of breathlessness. Her exam is normal. Her vital capacity is normal. Total lung capacity normal. Diffusive capacity mildly depressed. Her CT scan is unremarkable for interstitial lung disease. And an estimated right ventricular systolic pressure by echo is slightly elevated, and her laboratory parameters are normal. Think of the occult pulmonary vascular disease that is so common in this disorder. You see the same kind of vascular changes that we see in the kidney and in the finger that I talked about earlier, and it's like the trimming of a tree, slowly occurring over years. And this is something that you can see your patient that comes in with a CREST syndrome in 2000, and then in 2020, they're all of a sudden breathless, and you have pulmonary hypertension years later. And so the lesson that I want to teach is to pick it up early. And one of the things that we now are moving from is the definition of pulmonary hypertension has been changed. And the reason for this is that patients that had right heart cath that fell under the 25 millimeters of mercury that was a definition of pulmonary hypertension, say they were 20 millimeters or 22 millimeters of mercury, if you followed those patients with mild elevations, they progressed to develop pulmonary hypertension in a large percentage, of over a third. In addition to that, the prognosis for those patients that we waited on till they did develop definite bad pulmonary hypertension is bad. The outcomes is terrible. So the definition now of pulmonary hypertension to pay attention to by right heart cath is now 20 millimeters of mercury with a normal wedge pressure and a PVR of 3 Wood units. So if I have a patient that comes in and they're not symptomatic and I'm screening them and they have a normal echo with a normal ejection fraction, a low right ventricular systolic pressure, no dilated right ventricle, and I'm going to tell you, you need to look carefully at the right ventricle in these patients. Then those patients I follow and I repeat the echo in a 6-month interval. And those individuals who have a normal ejection fraction and their right ventricular systolic pressure falls into this gray zone, 40 to 45, and the echo is otherwise normal, then we are doing a bicycle exercise test. And we're doing that in order to provoke, to see whether in an exercise setting they develop pulmonary hypertension or not. If their peak right ventricular systolic pressure goes up with exercise to over 50, there's a high percentage of those people having a positive right heart cath defining pulmonary hypertension. So the exercise test in the asymptomatic patient has been helpful. If they have on their echo a high right ventricular systolic pressure, and in particular if there's a right dilated ventricle, then we move them for early detection to a right heart catheterization. Now remember, review the risk factors, and I'm going to go through some of these with you. If the patient is symptomatic, they come in with breathlessness, and they have that same intermediate right ventricular systolic pressure without dilation, we move them to a cath study. If they're symptomatic and have a right dilated ventricle or an elevated pressure, we move them to right heart catheterization. And of course, we look for other causes for pulmonary hypertension, such as a VQ scan, a sleep study for sleep apnea, and so forth. These are the risk factors. If you have a patient with scleroderma and they have numerous telangiectasia, that patient has an added risk for developing pulmonary hypertension. I had one of my fellows count the dots, and if you count the dots and look at the estimated right ventricular systolic pressure, there's an association between numerous telangiectasia and pulmonary hypertension. This is striking in patients that have diffuse lung disease or diffuse skin disease who are at lower risk for pulmonary hypertension. If they survive long enough, you'll start seeing telangiectasia that start developing in their skin. They start to look like a CREST patient, and sure enough, later, they can develop pulmonary hypertension as well. The other factor is on the pulmonary function testing. A declining diffusing capacity can precede pulmonary hypertension by years. So if you have lung function tests and you see the DLCO go from 70 to 50 to 30, that declining DLCO associates with the development of pulmonary hypertension, and you need to look very closely at those patients. A decreasing DLCO is an excellent predictor of the development of isolated pulmonary hypertension. To define whether this is PH or PAH requires a right heart cath, of course. The other biomarker that's helpful is a pro-BNP. A pro-BNP level that's elevated is a precursor, again, for predicting that their right heart is in distress. And even modest elevations can predict a poor outcome and the presence of pulmonary hypertension. I use this in particular in those patients that have interstitial lung disease, and they have the quandary of whether pulmonary hypertension is in the background or they get a pro-BNP. And if it's elevated, then worry about pulmonary vascular disease or cardiac distress that's occult. The pro-BNP levels are significantly higher in patients with PAH compared to patients with idiopathic pulmonary hypertension, despite the fact that hemodynamically, when right heart cath is done, are similar. The outcome in our scleroderma patients with a high pro-BNP is worse than those with idiopathic pulmonary hypertension, and I'll try to explain why that is. So the risk factors for predicting pulmonary hypertension are listed on this slide: late age of onset, limited scleroderma, severe vascular problems like Raynaud's, telangiectasia, falling diffusing capacity, a rising estimated right ventricular systolic pressure. We showed that as a population, if the right ventricular systolic pressure goes up by 6, it increases the risk of developing pulmonary hypertension. Now, as an individual patient, that's not as important. A pro-BNP and the presence of certain autoantibodies that are nucleolar in location, in particularly anti-U3-RNP. African-American young woman that comes in with U3-RNP is at risk for developing early pulmonary hypertension in the course of disease. So be especially careful in taking care of those patients. And long-standing disease. Remember, this is an occult, something that's hiding on you. You don't see it, you don't respect it, and then when it comes, it bites you, and the patient does not survive. This is just an example of a 70-year-old gentleman with all those telangiectasia. And look, there he is in 2006, normal lung function, all the way to 2013. Then his lung function started to decline, and he developed bad pulmonary hypertension and unfortunately died shortly after. Lung function test showed a normal high-resolution CT scan. It's totally a vascular process. Scleroderma-associated pulmonary hypertension occurs in about 8 to 12% of all cases and can occur in the presence of interstitial lung disease. And the patients that have interstitial lung disease and pulmonary hypertension, they're especially bad, not only because of the complexity of managing them, but the outcome is very poor. Despite advanced therapies, the 3-year survival in scleroderma-associated pulmonary hypertension, unlike idiopathic pulmonary hypertension, is about 50%. And what are they dying from? And this is a major lesson that I wanted to make sure that we got across today. They're dying of right heart disease. That's peculiar to scleroderma. Someone came up and asked me, why are we not thinking more about the heart in scleroderma patients? Arrhythmias and heart distress is a cult, and we often don't think about it until they're come in with a catastrophic loss of function. What we have seen is that survival in scleroderma and pulmonary hypertension is worse than other forms of pulmonary hypertension, primarily because of occult right heart disease. And we've discovered this by, during catheterization, doing this loop study that I know you're all familiar with, where you can measure the contractility by looking at the pressure loops during heart catheterization. And what we found is that when you compare patients with idiopathic pulmonary hypertension to scleroderma, is that those patients with scleroderma have a depressed contractility, and the right heart begins to dilate with exercise, while the patient with idiopathic pulmonary hypertension maintains contractility. And that dilatation of the right heart shows that the right heart is sick in those patients. That's unexpected. We also have done this technique of looking at the echo in a special way, where you can see defects in the right ventricular function that you don't see on a conventional echocardiographic study. And again, pointing out that the right heart is sick. In addition, a slide that I'm not showing you is our specialist has done a right heart cath and done endomyocardial biopsy, isolated the myocytes from patients with scleroderma, and those myocytes are malfunctioning in vitro compared to controlled patients who have other forms of pulmonary hypertension and had the same studies done. So the right heart cath is especially vulnerable in patients with scleroderma, and we need to think about not only screening for pulmonary hypertension, but how do we protect the heart? And talking with my cardiologist, they don't know yet what to do in terms of protecting the right heart, but I want you to be aware that this is something coming into the future. Is it fibrotic disease, little patches of fibrosis? Is it myocyte dysfunction? Is it immune-mediated? Should we immunosuppress these patients? There's a study, as you may know, of looking at rituximab in the treatment of pulmonary hypertension, suggesting that an immune injury may be behind this. So there's lots of interesting research that's going on. The therapy for pulmonary hypertension, I'm not going to spend any time on today, but the main lesson is that we're now understand that monotherapy is not as effective as combination therapy. So our patients that are coming in, where we used to stay, if they're in class 1 or 2, we would just start a phosphodiesterase or endothelin receptor antagonist. Now we're using combination. But if they have severe disease, we're going right to prostaglandin therapy, whether it's IV, inhaled, or oral. And in combination therapy, the outcome has been significantly better if you use combination therapy and you use it early. But the lesson that I wanted to get across to this group is early detection. Be sensitive to the fact that although it's a group of around 12%, it's a deadly group, a deadly problem that affects these patients, and early detection and intervention may make a difference. Lung transplantation is an option in our patients. The one thing that people will reject patients for is they have significant gastrointestinal reflux disease, because if you reflux, it increases the risk for rejection, apparently. I've not had that happen in our patients. The survival after transplant is on average around 5 years, so it's a life-threatening strategy in these patients that you use, but it is an option for patients with scleroderma. We just published, if you're interested in reading, we looked at all the patients that had a single lung transplant. We had between 2 different institutions, and there was a series of about 12 patients or so. And we looked at what happened to the parent drug, the lung that was left, versus the new lung that was put in over years. And we had a long-term follow-up. And what we found is that the lung, the scleroderma that was left, worsened over time. And the transplanted lung stayed healthy over long periods of time with minimal fibrosis, and the main thing was rejection that would happen later. It's as though the inherent drug of the patient's own lung continued to have autoantigens or was still being driven to be injured, while the new lung did not. Thank you so much.
Okay, we'll have just a couple of questions. Please come to the microphone here. There, go ahead.
Great talk. Do the antifibrotic medicines have any effect on skin fibrosis?
Yeah, the studies were not directed at the skin, so we really don't know that it'll have a benefit for the fibrosis of the skin. You would think it might, but the studies were not included for that that group of patients. I should say that the skin did not in the trial show any great benefit, nor did the outcome in terms of patient measures of how they felt. Their breathing didn't get any better, and their quality of life did not get any better. But it wasn't designed to look at the skin.
Okay, this microphone over here, and then we'll come back over here for at least one more question, maybe 2.
Sorry, I just remain confused about one point, which is the skin disease. You know, you emphasized the fact that early on in the disease, you get a it kind of fixes itself. Yet, in your second case, and throughout your 2 talks, there was a lot of talk about giving immunosuppressive therapy for patients and then withholding the CellCept and having flare-ups of the skin. So I'm just a little confused. Is this idea that the skin does not heal itself as part of the natural course of scleroderma?
Yeah, that's a great question. So the question is why does the skin flare up if the natural course is one of improvement? And I have to say that my many years of taking care of scleroderma patients, I thought, unlike lupus or other diseases, that once their disease went into remission, I could stop drugs and they would be quiet and the skin wouldn't flare because of natural course. And what I found was about 20 to 30% of the time, patients flare and they recapitulate what they had at the beginning and go through the whole sequence again. And they can have what's independent of the skin is, even though the skin can go into a quiet state, you can have pulmonary vascular changes occurring, you can have interstitial lung disease occurring, these other organ compartments can go their own pathway. So flare-ups can occur. And so I'm more likely in 2019 to move people from high-dose immunosuppression to maintenance medication, such as myclophenolate at low dose, rather than stopping, particularly if they've been very sick. But it's a very good point that you bring out.
Thank you.
Okay, one or two questions, quick questions here, and then of course we'll have lots of time this afternoon at the panel.
In
Steve?
the severe patients who have hydroxyapatite deposition, I don't know if it's been written about, studied about, and I didn't hear it today, about perhaps inducing states of hypoparathyroid or hypophosphatasia or keeping vitamin Ds very low as a way of preventing
Yeah,
further
those
calcinosis.
those are all great questions. The principle is if I have 10 patients that look exactly the same, why would 5 of them get a heavy burden of calcinosis and the other 5 not? So is there another lesion that I'm missing? And so I started looking, because there is this, there's familial defects in calcium metabolism that lead to calcinosis as well. And they look just like the calcinosis we have in our inflammatory diseases like scleroderma skin disease. And so I have collected phosphate excretion in patients, and I did find in a patient, for example, that she had a low phosphate excretion, and so I said, okay, I'm going to do some of the strategies that you to try to wash out the phosphate, make sure that I wasn't overdoing vitamin D or calcium supplementation. It had no impact and that's in fact that lady that I showed you with the heavy burden.
That's
She
why I
was the
brought
one
it
that
up.
she has a low excretion of phosphate,
Because I
but her
was-
serum phosphate calcium were normal, but her excretion was low. So maybe there's another defect that we should be thinking about.
In lieu of your patient, I ask that because if it's the same calcification, she should have coronary calcification, she should have renal stones.
Yeah,
so
she
it-
doesn't.
Right. So
Yeah, she
Thanks.
doesn't. She has scleroderma.
We have one more quick question here.
So I was just wondering if you have anyone in your practice who maybe had, severe skin disease and ended up getting transplanted that also had a component of ILD, and whether or not transplant had an effect on that.
I'm sorry, say it.
For the bone marrow transplant and scleroderma with severe skin disease, like if anyone in your practice had an aspect of ILD and how transplant affected it.
I don't know if I heard the question entirely.
I'm not sure, I didn't get it either. One
So-
more time?
It was just.
I'm just asking
It's just
about-
the microphone's making it blurry, and then my ears are.
Sorry, I'm asking about bone marrow transplant
Yeah.
in scleroderma, and if any of your patients happen to have an aspect of ILD,
Oh,
and what
okay.
happened to it after
So you're
transplant.
talking about the immunoablation with stem cell recovery program. Is that what you're talking? Yeah.
And
So-
what happened to the
yeah.
ILD? in
Yeah,
particular?
so, there was a stabilization of lung function test as a population. I have to tell you that the focus of those studies was the skin.
Yeah.
So that again, it's not as though they say, okay, let's take patients that just have a predominant problem of interstitial lung disease. And so one of the trials, they looked at death or the evolution of new organ damage, which would include moving to progressive end-stage lung disease. And in those patients, there was less lung disease decline compared to the group that was not treated. The question, though, is was that the high-dose Cytoxan, or did stem cell bone marrow, as you put it,
Yeah.
play a role? And it's not clear that that's the case. I haven't, if I look at 100 of my scleroderma patients and try to find with patients that I would do a stem cell transplant, I have a hard time finding somebody.
Thank you, Fred. So we're going to take a 15-minute break, and then we'll come back for difficult APS.
Son los pacientes que no dejan de joder.
We'll get started in just 1 minute. Okay, we'll start in just about 30 seconds. While waiting for everybody to get back to their seats, just wanted to make a couple of announcements. First, the link for the presentation slides will be sent to you by the Harvard Medical School Continuing Medical Education Program. So you should get a link from them through your email, which will contain the link to the slides. A quick reminder about the welcome reception tomorrow at 5:30 at the conclusion of the panel. It's going to be in the Regatta Bar, which is on this floor, just on the other side of the elevators, very close by. And finally, in the program, both for today and tomorrow and Tuesday, the last event of each day was left off. So we are having a panel session today. We are having a panel session tomorrow, following which we have the reception. And then on Tuesday, the last event of the course is in New England Journal of Medicine CPC. David Hellman from Johns Hopkins is going to be the discussant of an unknown case. The title of that CPC is the last or the next to last page in your book. And we'll pass out the protocol for the CPC so that you can read it, hopefully tomorrow, so that you can read it in advance. It's a spectacular case. All right, so now we're going to move on to difficult antiphospholipid syndrome. And I really have the sense in talking with Doric this morning and throughout the day that for the first time in a long time, we are poised to make some real advances in antiphospholipid syndrome over the next few years. And after describing the phenomenology of this problem for a long time, it's becoming very granular now, and some individualized treatment approaches that are more than just anticoagulation have come along. So I think you're going to find this very interesting. Doric?
Thank you very much. I'm back again, and as you know, we covered the basics this morning. Now it's time to move into the details, talking about difficult cases, what I call scary APS. However, after listening the last talk, I don't know which one is more scary, systemic sclerosis or catastrophic APS. So let's go over definitions first. It is not easy. I'm sure you all heard about catastrophic APS classification criteria, meaning 3 or more organs involved with thrombosis. Things happen quickly, usually less than a week. There is usually microthrombosis as part of the picture, and then persistent APL. Looks very clean on the paper, but no patient presents like this. As patients do not present like that, there is also a probable CAPS definition for those fulfilling 3 out of 4, meaning only 2 organs involved. Things happen in a month despite anticoagulation. You cannot confirm microthrombosis or APL tested only once. And this morning I made the point that microthrombotic APS is really different than catastrophic APS because these patients come to your clinic. They are not in the unit. Even if microthrombosis is part of catastrophic APS, there are patients only with microthrombotic involvement, such as diffuse pulmonary hemorrhage, APL nephropathy that can be acute or chronic, livedoid vasculopathy, that's actually a pathologic term, and that's because of skin microthrombosis, cardiac microthrombosis, adrenal infarcts, and these patients may or may not have thrombocytopenia as well as anemia. And when I talk about non-thrombotic APS, there will be patients with thrombocytopenia, hemolytic anemia, immune-mediated, and valve disease, vegetation or thickening that can happen in APL-positive patients. So when we start to talk about catastrophic APS, microthrombotic APS, non-thrombotic APS, we are really getting into the discussion of thrombotic microangiopathy. And to define thrombotic microangiopathy, let's just start from the basics. Angiopathy, there's a problem with the blood vessels. Microangiopathy, problem with microvessels. And thrombotic microangiopathy is ischemia due to fibrin formation or platelets aggregation. And as I mentioned, these patients may or may not have schistocytes and anemia, part of it. Thrombotic microangiopathy is different than thrombotic microangiopathic syndromes. And usually, besides thrombocytopenia and microangiopathic hemolytic anemia, there is an organ involvement in thrombotic microangiopathic syndromes, mostly kidney. Sepsis, HIT, DIC, CAPS, they are all covered under the umbrella of thrombotic microangiopathic syndromes. And of course, HELLP syndrome. You may have two patients developing HELLP syndrome, one with APL, one without APL. The one with APL will have a poor prognosis, more liver infarcts, doesn't really respond to delivery, requires CAPS-like management. So the point I'm trying to make is, yes, we talk about CAPS in the ICU when patient has sepsis or HIT, but is it really CAPS or just APL making the picture worse? We'll talk about the diagnosis. It may be very difficult to differentiate. This is a table describing the causes of thrombotic microangiopathy. It can be hereditary, acquired, primary, and acquired secondary. If you look at the first item under hereditary, that's TTP. First item under acquired primary, again TTP. And this is either genetic or not. But I want you to focus on the complement-mediated TMA. In fact, complement-mediated TMA is the new name for atypical HUS. Probably you heard about atypical HUS, defined as thrombocytopenia, microangiopathic hemolysis with normal Adams-13 activity to rule out TTP, negative infection to rule out HUS, and then one of the organs involved can be neurologic, renal, or gastrointestinal. So if you read an atypical HUS article or clinical trial, this is the definition to get into trial. And I guess you can see the similarities between this picture and catastrophic APS. And I mentioned there are two forms of complement-mediated TMA, one hereditary, and these kind of patients, 50% will have genetic mutations, and there are tests or laboratories offering these tests. And interestingly, there are two recent papers. These are lupus and or APS patients presenting with atypical HUS or complement mediated TMA type of picture. Two different centers in United States. All patients had normal Adams 13. In one study, they also look at the complement regulatory protein mutations, and these patients responded well to atypical HUS treatment, which was eculizumab, and we'll talk about that in a second. And the point here is clearly there is an overlap. Lupus, APS, CAPS, some of these patients may have genetic tendency to have a more severe picture. A couple of examples about microthrombotic APS. 52-year-old male, DVT, PE, triple APL, long-term warfarin, doing very well. And 2 years after presenting with diffuse alveolar hemorrhage, skin ulcer, creatinine 2.5, platelet 80,000, and mitral valve vegetation. This patient doesn't fulfill the first slide, the CAPS criteria, but if you do not start an aggressive treatment, prophylactic plan, for sure he's going to develop CAPS. So it's very important to catch these patients early. Another patient, 42-year-old female, 2003, PE, triple APL, on warfarin. 6 years later, MI and diffuse alveolar hemorrhage. 3 years later, biopsy-proven APL nephropathy with mitral valve disease, recurrent diffuse alveolar hemorrhage attacks, white matter changes, cognitive dysfunction, and there are actually now advanced cardiac MRI techniques, including stress MRI, that can suggest microthrombosis and TIA. You know, we had several patients presenting with coronary syndrome, coronary is normal, and that's because of cardiac microthrombosis. So these are the scary type of patients that I am generally worried. And with respect to diagnosis, I mentioned that there will be International APS Congress next week. And over there, I'll give a talk about unmet needs of catastrophic APS. And I'm just going to build on this slide. We need clarity on definitions from a mechanistic point of view. Not every patient is the same. And we need to use tests to help us better classify, diagnose these patients. You know, there are some laboratories offer atypical HUS panels. Some laboratories offer complement mutation panels. Sometimes we rely on biopsies. But can we differentiate these patients better from a mechanistic, prognostic, and treatment point of view? Not every patient fulfilling CAPS criteria has a problem because of antiphospholipid antibodies. And while making the diagnosis, rule number one, history. I don't need to tell you this. A few years ago, we got a consult, history of lupus, active kidney, and GI disease, consult for lupus flare. And when we talked to the patient, the real story was preeclampsia 28 weeks, triple APL positivity, acute TMA, APL nephropathy, and mesenteric ischemia. And the patient got the biopsy, showed, actually no, that was the history, biopsy-proven TMA, and eventually developed thrombocytopenia, intracardiac thrombus, liver microthrombosis, and seizure. So this patient did not have lupus. Uh, Another diagnostic challenge is this slide is important for your phone calls Friday 5 p.m. from ICU. We have a CAPS patient. Many patients admitted to ICU can have positive APL, including lupus anticoagulant, for so many reasons. Here, 51 ICU patients, no thrombosis, no anticoagulation, no immunosuppressive treatment. 53% had positive LA test, all resolved after the discharge. And clearly, infections or problem with the interpretation of the tests can be an issue. What are the challenges while making diagnosis? Positive APL can be seen during infections or false positive with anticoagulation. We talk about that. Rare but false negative APL reported during acute CAPS events. We talk about this big umbrella of thrombotic microangiopathies. There are significant similarities between sepsis and CAPS, HIT and CAPS from a mechanistic point of view. And there are some algorithms that may help with CAPS diagnosis. The first thing is history of APL positivity or APS. And 50% of patients presenting with CAPS or CAPS-like picture will have this history. And when there is history, it's relatively easy to think about that and to be aggressive. And this is the first algorithm in the setting of positive APL. You just follow few steps. But if patient doesn't have that history, you may go to algorithm B, algorithm C. It may not be easy. And again, anybody interested in the references, please email me. I will be happy to send you the papers. So, management. With respect to microthrombosis, it can be a red flag for catastrophic APS. And the definite CAPS criteria, patients do not present like that. It's just step by step. So we need to be very aggressive. And the chronic microthrombosis patients that you see in your clinic, they do not respond to anticoagulation. So we need different approaches. We use medications. That's part of traditional CAPS management. And let me talk a little bit about CAPS management here. There is an international registry, approximately 500 patients of CAPS, created based on published case reports. So there's a lot of publication bias there. But right now, that's the only tool that can provide some data. And based on this registry analysis, triple therapy, not the RA triple therapy, it's the anticoagulation plus steroids plus plasma exchange and or IVIG. This is how the best outcomes are achieved. Here you see overall mortality 37%, with triple therapy 27, other treatments 41, so it improves survival a little bit. This is most recent guidelines about the diagnosis and management of catastrophic APS. There are 10 recommendations, 3 on diagnosis and 7 on treatment. Conditional, very low certainty of evidence. And as you can see, that means very weak recommendation, the one on the right. Other alternatives may be equally reasonable. And what are they? Conditional recommendation, very low certainty of evidence, suggestion. For the first line, steroid plus heparin plus plasmapheresis or IVIG, yes. Plasmapheresis, yes. IVIG, yes. Rituximab and steroid alone, no. A group came together, first organized the questions, there was literature review, and there was a meeting, and based on discussions, these recommendations were created in a systematic way following the McMaster guidelines. And then strong recommendation, very low certainty of evidence, therapeutic dose anticoagulation, antiplatelet as an add-on therapy, yes, which makes sense. However, CAPS management is not easy. We cannot just say, oh, this is CAPS, give the triple therapy. We make decisions based on, is there an infection? Is there an HIT? Is it TTP? Is there bleeding? As we speak, actually, I am treating a CAPS-like patient on IV heparin despite GI bleed. So sometimes strange things happen, but we may not have any other choice. Severe thrombocytopenia, renal failure, other autoimmune diseases, vascular access, you make a decision based on this. And everything needs to be done on a multidisciplinary fashion. The first thing to do if you are seeing a catastrophic APS patient is starting an email chain. It's extremely critical because there is a bleed, you want to start anticoagulation, you'll tell the ICU, ICU calls neurology, fellow says, I will check with my attending, they get back to you in 6 hours, it goes to hematology. It doesn't happen like this. Everything needs to be on an email quickly. Right now, I have 2 separate email chains going on, 1 email chain with 30 people. And, you know, it just people keep adding the on-call person and this person and that person. You have to make difficult decisions, and somebody needs to make the decision. Like, we know that whatever you do, things may go wrong. You start bleeding, you start heparin, it will bleed. You don't start heparin, it will clot. In order to avoid that people are blaming each other, you make the decision all together, despite that somebody is needs to say, time to do this. And really, as a rheumatology, we should be on the top of everything. Yes, somebody. I don't want to scare you, but so immunosuppressive approach. Why we are thinking about immunosuppressive approach? Because this is a very simple cartoon demonstrating APL-mediated mechanisms. Sorry, I don't have a pointer, but on the left side, you see the B cells, antiphospholipid antibodies binding to endothelial cells through receptors that causes endothelial cell activation, complement activation, tissue factor, major trigger of coagulation system, and then you get the clot. And currently, when we talk about treatment, or this morning, when we talk about the treatment, we were really focusing on the right side of the slide. Anticoagulation. Keep in mind, heparin can also inhibit complement based on mouse models. Inhibition of platelets like aspirin. Keep in mind, both hydroxychloroquine and statins can also inhibit platelet. We talk about plasma exchange or IVIG. Can we eliminate B cells and antibody production? And we'll talk about rituximab a little bit. We'll talk about complement inhibition a little bit, and then blocking antibodies or blocking tissue factor upregulation. That's more further down in the future. So what are the medications we use in these patients? Very briefly, hydroxychloroquine, statins, traditional DMARDs, B-cell inhibition, complement inhibition, and mTOR inhibition. And the New England Journal of Medicine article that I mentioned this morning, there's a summary. It's brief, but there's a summary of when these medications can be used. Let's talk very briefly about these medications, and I will be happy to answer your questions. Hydroxychloroquine, I don't need to describe hydroxychloroquine to this group. Probably you know that also it was used for DVT prophylaxis after hip surgeries in the past, but very high doses. And it has antiplatelet role. There are also models showing that it can interfere with APL-mediated clinical problems. Here you see the antiphospholipid antibody kind of like 1 p.m. direction, binding to platelets, activating, and hydroxychloroquine can actually inhibit that. In mouse models, you can inject antiphospholipid antibodies, but nothing happens unless you create a pinch injury or laser injury. That's the support for second hit hypothesis. And also hydroxychloroquine can decrease the time, decrease the thrombus size in these models. We all know that hydroxychloroquine is protective for thrombosis in lupus patients. Here you see some of the articles. Some of them are actually barely statistically positive. Clearly not an APL-specific effect. There may be other reasons. There may be confounding by indication that mild cases receiving hydroxychloroquine. But not every article talks about these two studies showing that hydroxychloroquine does not decrease the risk of thrombosis in lupus patients. So I want you to be aware of these. There is only one very small study in primary APS patients, 40 with venous events, 20 received anticoagulation, INR 2 to 3, and 20 received anticoagulation plus hydroxychloroquine with higher thrombosis risk in the anticoagulation alone arm. That's all. And APS Action is an international network created almost 10 years ago now, and we have around like 25 centers all around the world. We have an international registry of 800 plus patients right now. One of our first attempts was trying to study hydroxychloroquine for primary thrombosis prevention. The trial failed or early terminated for so many logistic reasons. I will be happy to send you the paper if you are interested to know what happened. And that does not provide any useful information. So what do I do in difficult to treat patients? This can be microthrombotic APS too. I add hydroxychloroquine. For secondary thrombosis prophylaxis, no lupus-like disease, or for primary thrombosis prophylaxis, no lupus-like disease, I do not add hydroxychloroquine. Statins. Every specialty is studying this drug. It has so many other roles besides lowering the cholesterol. Also, there are models, mouse models or in vitro studies in APS that it can inhibit APL-induced endothelial cell activation or upregulation of tissue factor. Many years ago, with Silvia Prangiali, we completed a study that APL-positive patients with or without lupus, for 3 months they received fluostatin, and then for 3 months they were off fluostatin. So 6-month follow-up, and these are not acutely thrombosed patients anytime. And we looked at these inflammatory and prothrombotic markers. In this slide, first column, 41 APL-positive patients compared to 30 controls. You see some of these markers elevated. Let's look at tissue factor, for example, the one on the bottom, it's increased in these patients. And with treatment goes down, if you stop treatment, goes up. Clearly, this is not a clinical outcome study, but something we can consider in difficult to treat patients. And of course, if they have hyperlipidemia. With respect to B-cell inhibition, there are two mouse models showing that APL is involved, both from Dr. Davidson's lab. One of them, CTLA for IG, prevents initiation of the disease. The other one is BAFF blockage, can prevent the disease onset and prolongs survival. Again, no need to describe what rituximab is to this group. And there have been case reports of rituximab used in APL-positive patients, mostly for thrombocytopenia or hemolytic anemia. We also had good experience with skin ulcers or livedoid vasculopathy. That's why, again, many years ago, we designed this pilot study for non-thrombotic or microthrombotic manifestations of APL. And all patients, this is pilot, no placebo involved, 1 cycle of rituximab, 12-month safety, 6-month efficacy, follow-up. And actually, there are 3 points I want to make. Number one, whenever I see these microvascular CAPS type of patient, usually they are triple positive, very high levels. When I talk about high levels, I'm talking about more than 150, more than 80. In my experience, those type of patients get into trouble with respect to this clinical phenotype. In our study, 12-month follow-up, no change in APL profile. So there may be comments from hematologists, oh yeah, let's give rituximab, let's bring the titers before the surgery. We also reviewed the literature. There is no report showing that a clinically significant APL profile becomes negative. What I mean is, you can find a report, anticardiolipin mean 27 becoming 19, but nobody checked lupus anticoagulant, like low titers becoming negative doesn't really help. Yeah, in our experience, titers do not really go down. However, the good news is there were some patients responding to rituximab. Very small numbers, pilots, so I accept that. 50% in thrombocytopenia. Skin ulcer patients did very well. There was 1 patient with APL nephropathy, partial response, and these patients with cognitive dysfunction, neuropsychiatric test proven at baseline, 6-month follow-up with improvement. Unfortunately, we don't have the controlled follow-up study. There is one analysis from the CAPS registry, small numbers, rituximab to receiving patients, maybe doing well, but it's really very small numbers. No other data that I can present. So when do I use rituximab? For thrombocytopenia or hemolytic anemia, sometimes I use it. But I also had good experience with traditional DMARDs like Imuran. APL nephropathy, together with Cellcept, we use it. Diffuse alveolar hemorrhage management is very complicated. We just published a review article and our experience, sometimes part of the regimen. And in catastrophic APS, when I feel like there is a traumatic microangiopathy type of picture going on, I do. Do I get a positive response all the time? Not necessarily. And then complement inhibition, very hot topic nowadays. Mouse models suggest that complement is involved in APS, and if you can inhibit complement in pregnant mouse model, you decrease the risk of APL-related pregnancy issues. Eculizumab, it's an complement inhibitor, blocks the serum hemolytic activity by preventing its cleavage into C5a and C5b, so it's anti-C5. This medication requires chief financial officer approval at New York Hospital because it's $27,000 per infusion, okay? It's not easy to use this medication. You are going to see some case reports of eculizumab use in catastrophic APS. Many of these reports CAPS patients developing rejection after kidney transplantation after the CAPS episode is over. And I want to just tie it to the previous discussion that in a patient with atypical HUS-like picture or complement deposition or complement mutations, it may be an option to think about. We have patients with different manifestations, different success rates, and I have one patient with transplant rejection. We spent 6 months to prepare her for transplant, but things can go bad in these patients, and actually doing well. Again, if there are any questions, I'll be happy to answer. And the last thing is, this is 2014. One day, all of a sudden, a French group published a New England Journal of Medicine article about mTOR pathway. And they showed vascular endothelium. So I'll tell you what mTOR is, but they showed mTOR activation in this vascular endothelium of APL nephropathy patients and also in cultured vascular endothelial cells. And more interestingly, they had this group of patients receiving transplantation. They looked at functional renal allograft at 144 months. And if they are on sirolimus, which is an mTOR inhibitor, those patients did better compared to sirolimus untreated ones, in addition to the standard of care. So what is this mTOR business? It's mammalian target of rapamycin, regulates cellular growth, proliferation, and survival, and responsible for endothelial proliferation. And sirolimus is a medication used after transplantations, heart transplantations. It's available right now. So why endothelial proliferation is red? Because we see endothelial proliferation in kidney disease, in placentas, in brain, in livedo, pulmonary hypertension, and basically that's the reason we started to talk more about APL vasculopathy. There have been one case report of sirolimus use from Italy in a patient with cardiac microthrombosis, and I have one patient that we are going to report next week on sirolimus. It's not an easy medication to use, requires blood level monitoring. I think it's important to work with the nephrology team because they are more familiar with the medication, and actually I'm about to start a second patient on this medication, but clearly we need more data, controlled data. I'm just telling you a few examples. Just don't see it as an RCT data. So basically that's the end of my talk. If you have any questions, I am here. You can email me anytime. And also, this iBook is free to download. I think it's a great teaching tool for medical students or residents just covering the basics of APS. Thank you.
Okay, we're going to hold questions for Doric right now. If you have questions, please write them down and bring them up because we're going to move right into the panel. And we'll start in just about 60 seconds. Thank you. Great.
Excuse me? I said you look like a big pile. Well, here, let me give you some. Here's one that you can work on. That's because you... I can't.
I can take this one.
Okay.
Yeah. Tour inhibition, APS.
Okay, great. Okay, so we'll get started. We have lots of questions to get through. We have an hour to do it, and we have a Doric for only 30 minutes. So we're going to move quickly. Joe was here yesterday, so he knows about the gong. If the speakers go on too long in their answer, they'll get the gong, okay? Now, the problem is that the less the evidence, the longer the explanations. So you're going to have to be very careful not to be too long-winded. You're the experts, so give short, concise answers. Don't worry about quoting data or anything like that. Your opinion is much more important. Doric, why don't you start, okay, since you've got to head out the door at 4:30.
Right. So let me just answer this question quickly. Yeah, sorry. So very quickly, let me answer this question.
Yeah,
and then I'll try to
summarize the question first.
Organize them. So the question was about using elevated PTT as a proxy for lupus anticoagulant test if lupus anticoagulant test is not available. Now, what elevated PTT is a red flag to check lupus anticoagulant, but if your PTT is normal, you cannot exclude lupus anticoagulant. I think once we look at this, around like 40 to 50% of patients with positive LA have elevated PTT. So really, it needs to be the 3-step LA test.
Okay, good. That was nice and concise. Fred?
Does colchicine work for calcinosis and scleroderma? No.
Good. Nice and concise. All right. Joe, you're up.
In patients being worked up for transverse myelitis, should APL antibodies be checked? And the answer is no and yes. It used to be felt that antiphospholipid antibodies could be responsible for transverse myelitis in lupus, and there were papers to that effect, but to my knowledge, that's been disproven, and there's no role for anticoagulation in treating phospholipid antibody in treating transverse myelitis. On the other hand, if you want to know if your patient has lupus or not, and you're trying to decide, if lupus is part of the illness, then you might be checking them just for diagnostic purposes.
Okay, Doric.
In patients with lupus with no history of thrombosis, what advice do you recommend regarding oral contraceptive pills? Would you do antiphospholipid antibody workup? If you do, how does it change management? In my opinion, every lupus patient should be tested for antiphospholipid antibodies. And if they are positive, they should not be on estrogen-containing medications. If they are not, there are data suggesting that it's okay, but definitely not for APL-positive patients.
Great, nice definitive answer. Remember to speak right into the microphone, okay? Okay, Fred, you're up.
So the question is tendelavir versus sildenafil equally effective for Raynaud's in digital ulcers? Most of the evidence that has been done with in clinical trials is with sildenafil. There's been a negative trial with tendelavir. So sildenafil would be our preferred drug. Theoretically, you would think they would both work similarly.
So the question is, how specific are high-titer double-stranded DNA antibodies in patients who don't have typical signs of lupus? And the answer is it depends on the assay. For example, the Crithidia immunofluorescent assay is extremely specific for double-stranded DNA antibodies, and patients with really high-titer Crithidia DNA assays are very likely to develop symptoms of lupus if they don't have them. On the other hand, our current ELISA assay, we have people with polymyalgia who have high-titer DNA antibodies. So you just have to know how accurate your assay is.
So there are two pregnancy questions. First one is best treatment for a patient APL positive, 2 miscarriages, first trimester. And question A, if LA positive. Question B, if LA negative. Now we know that LA positivity is the best predictor of pregnancy-related events. So that changes the thinking a little bit. After then, I really want to know the APL profile, low level, high level. After then, I want to know first trimester when, 3 weeks or a little bit after 10 weeks. But this is really like there is no clear answer. As there are 2 miscarriages, I don't think you can say no treatment. Based on the other information provided, it's going to be aspirin and or heparin. And it's also a discussion between the patient and you. And supporter criteria say 3, but sometimes we treat patients with 2 miscarriages. The other question is about adding hydroxychloroquine in pregnancies. I do not add hydroxychloroquine at this point unless they fail the recommended treatment, which is aspirin and or Lovenox. And with Lovenox, you can increase the dose too. And this is for a non-lupus patient.
Fred, you're up.
So the question was, what are the role for corticosteroids in the treatment of inflammatory arthritis and scleroderma? I do use corticosteroids when necessary. The key issue is to low dose. The studies show that the use of corticosteroids may increase the risk for scleroderma renal crisis, and I'm particularly anxious in the patient who has the antibody to POL3 of using corticosteroids. Certainly, I do not want to use it in any patient above the level of 20 milligrams, and usually try to keep it under 5. But there are other options that I try to avoid steroids with, for example, methotrexate. Tocilizumab can be used as well.
What do you do with a patient with class 3 or 4 lupus nephritis who's after 4 months of treatment has low-grade hematuria, 6 to 10 red cells, and less than a gram a day of proteinuria, and it's been on 3 grams a day of CellCept? I keep treating them. The red flags for failure of treatment are, first of all, if after 8 to 12 weeks there's no improvement at all, the proteinuria hasn't fallen, the patients know better, and of course it has to be in the clinical context of otherwise they look like they still have active disease and they're not doing well. And then the second red flag is after 6 months to a year if they still have more than a gram of proteinuria, although that could relate to the severity of their nephritis and not necessarily to the fact that the treatment hasn't been effective for them. So if I had a patient who had worsening proteinuria, then I would consider rebiopsying and seeing what's going on. But I think in this case that the long-term history of proteinuria in patients treated with immunosuppressants for lupus, whether it's MMF or cyclophosphamide, is that if it's already getting better, it's going to keep getting better for a year or longer. And I would just wait and see. I think this patient would probably keep getting better.
Have you ever seen multiple bone necrosis as only manifestation of APS in lupus patients? The answer is I've seen 1 or 2 patients without lupus, no other risk factors for AVN, just all of a sudden it's AVN. That's why there may be an association between AVN and antiphospholipid antibodies. It's not well proven, and majority of the patients I see with APL and AVN have other risk factors.
A question is how often do you get pulmonary function tests in patients with diffuse scleroderma and limited scleroderma? And I think I want to emphasize again that the black and white classification of patients is not good enough, that you want to have a risk stratification based on other factors: young woman, African American, early disease, topo positivity, and your sensitivity for screening may be more intense. In general, a new patient, we get a lung function test every 6 months, and then in a stable patient, once a year. In the patients with no risk factors, and we might follow the clinical impressions of what we need to do for follow-up.
Question
But in a
is,
patient with risk factors, Fred, could I just probe a little bit? With risk factors, would you do more
Yeah, for
than every 6 months?
Risk factors is every 6 months that we
Okay.
do a lung function test. If stability occurs after some follow-up, then it's once a year. But any new symptoms or signs, particularly in a risk patient, it's every 6 months.
Okay, Joe.
so the question is there such an entity as ANA negative lupus? And I think this has to be interpreted in 2 ways. First of all, sometimes the ANA is just not accurate. For example, very high titers of antibodies can create a prozone phenomenon, or the technique may not really be working. And so some of those people really are ANA positive. Secondly, there are patients who meet criteria for lupus who are ANA negative. We did a study called the MILES Project that found 2,500 patients in southeastern Michigan, and we used ACR criteria and SLIC criteria, and also the investigator's review of the patient to see if they thought they really had lupus. And about 2% of our patients had ANA negative lupus, and by the investigator's definition, and about 4% by the criteria. And when the investigators decided there was lupus, there was always something else. There were cardiolipin antibodies or anti-SM antibodies. So that almost all the patients who were felt by the investigators to have lupus had some other autoantibody. And if you look at the criteria, there are hemolytic anemias involved, autoantibodies, thrombocytopenias. So I think that it's very rare to have lupus in which there are no autoantibodies demonstrated, even if the ANA is negative.
Okay, so Doric is going to start to do 2 questions in a row quickly, because he's got to leave at 4:30 and has a lot of questions to get through still.
Okay, you said quickly. Any oral contraceptive used in APS, nothing estrogen containing. Progesterone only, it's okay. Sirolimus for APS, we just discussed about that. It may have a role in patients with microvascular disease. But if I have 30 minutes, I
Go
want to
ahead.
answer this question.
No, 30 minutes? No, that won't work.
The question
30
is,
seconds.
what do you think about seronegative APS? This requires a 30-minute answer, but I will summarize in 30 seconds. You know, we talked this morning about overdiagnosis of APS. As soon as we introduce this concept of seronegative APS, it's going to get out of control. And we just need to be careful about the definition of seronegative APS. And I believe that there may be some patients who are negative based on the criteria tests, but may have one of those tests, non-criteria that we talked this morning, and those tests are not well standardized. They may be slightly positive, you repeated it, negative, and email me in a week. Probably I will have more information about the APS-PT test after the Congress, but at this point, I do not use the term seronegative APS.
The question is the prognosis of cancer different in patients with paraneoplastic, as described here, scleroderma? And does scleroderma resolve with the removal of the tumor? And it's a great question, and we don't know. Well, this is part of our prospective investigations as to whether or not there's a difference in the outcome in those individuals that have cancer and scleroderma. My impression is that there's not, and that I see cancer as being treated and under good control, and scleroderma going its merry way. So, but it's a great question that we're investigating further.
So the question is, 43-year-old person with lupus and APL on Plaquenil, Coumadin, persistently elevated DNA antibodies, SED-rate, C-reactive protein, low C3 and low C4, clinically well. Would you add another agent? No, but I'd watch the patient very carefully. I think that when people have really worrisome serologies, at least until you get used to the patient and realize that's what the patient's like after a couple of years, I think they are watched more carefully, and therefore they do get treated more because there's more surveillance for minor problems that could be treated. But I certainly have a low threshold for treating anything that was clinically appropriate.
The next question is about seronegative catastrophic APS. The answer is similar. Yes, there is one report of antiphospholipid antibodies because of consumption becoming negative during the CAPS event, but we just talk about the similarities with other conditions, and there can be so many reasons why somebody gets a CAPS-like picture. And the other thing I want to say is, I mean, let's call it seronegative APS, let's call it catastrophic APS, seronegative. Sometimes, or most of the time, it doesn't change the management. You just do whatever you need to do. It's not that important what you call. Is there a hemorrhagic form of APS? Yes. Diffuse alveolar hemorrhage is the first one that I can remember. That's because of microthrombosis resulting in bleed. And the other one is adrenal hemorrhage, common in catastrophic APS patients. And that's also happening because of adrenal infarct. Once we had like two notes in the chart, 5 minutes apart. Hematology said, adrenal hemorrhage, stop anticoagulation. Rheumatology said, adrenal hemorrhage, continue anticoagulation. Good case for lawyers, but if you can continue, you should really continue anticoagulation in adrenal infarct patients.
The question is whether there's a concern about using probiotics in patients who have scleroderma and immunosuppressed. I don't have any worry about using probiotics in this population. I think our gut is filled with millions of bacteria that may be bad guys. I'm not sure probiotics are having an impact on scleroderma bowel disease, but I'm sure that antibiotic therapy clearly helps patients that have the bloating and diarrhea syndrome that we often see.
Question is there such a thing as incomplete lupus? The original ACR definitions had possible, probable, and definite lupus as definitions, and I don't think the ACR definitions really get us there, but I think it's useful to have levels of diagnostic certainty less than the ones that are required to enter a patient in a clinical trial. You might say, well, maybe a lower score is needed to start somebody on Plaquenil, for example. And to me, the incipient lupus, which I prefer, is the point at which I would talk to the patient about whether or not they want to take Plaquenil to suppress the symptoms they have and prevent the emergence of new symptoms. So I do think before the diagnosis is ironclad as required by criteria, that there's a point at which it's sufficiently likely that the disease is manifesting itself, that the discussion should occur about using hydroxychloroquine.
The female patient with livedo reticularis and no history of obstetric or vascular events, do you still check antiphospholipid antibodies? If I am seeing the patient or if a rheumatologist is seeing the patient, there is a reason, so I do check that. But I also want to make the point that livedo reticularis is different than livedo racemosa. Reticularis is relatively common in general population. That's just a circle, and patients will report that it just gets worse with cold. Racemosa, which is more important, more specific for APL positivity, that's more like aggressive broken circles. And there are few studies suggesting that patients with levodopa at a higher future thrombosis risk. But the short answer is yes, I do check it. Let me do something quick. Which are the most important secondary risk factors to eliminate? I think the most important general population thrombosis risk factors are the important ones, but surgery, birth control, pills, management of cardiovascular disease, flights. So I usually, there's this discussion about low molecular weight heparin or not. Let's not get into there. But I'll see walk, drink, exercise. That takes care of most of the patients.
First class.
First class, definitely. It's not an issue in first class. Yeah.
So the question is, do you have any recommendation for the improvement of a cosmetic appearance due to the distressing telangiectasia? These can be removed with laser ablation very effectively. Unfortunately, they do tend to reoccur, and the laser therapy is not generally covered by insurance because it's considered a cosmetic thing, but it can be done, and many of my patients will opt to do that. They charge by the dot, so you can go after the ones that are hard to cover with cosmetics.
Would you give all patients with lupus a cocktail of ACE inhibitors, aspirin, and statins lifelong? I used to have a slide that I put in my lectures called the lupus pill, and it had a little bit of hydroxychloroquine and a little bit of aspirin and an ACE inhibitor and a statin. And certainly, I think that this needs to be done as required by the patient, but this is not unusual for patients to require many or all of these. When I wrote a paper about lupus nephritis in the 1990s, all my patients with nephrotic syndrome had cholesterols of 250. And now if you look at populations, everybody's well controlled. The LDLs are down, and so it's often necessary to think about using all these things, although I do individualize.
The recent EULAR recommendation says to treat unprovoked venous events similar to patients without APS. I think it's going to be provoked venous events similar to patients without APS, if not high-risk profile. Your opinion? My opinion is we are really trying to understand if we should manage APS patients in the long run different than the general population. Because don't forget, general population, unprovoked DVT, the recommendation is lifelong anticoagulation, assessing the bleeding, the risk regularly. When it is provoked, it's a different story. And as I discussed this morning, there are patients with provoked APS events that I feel comfortable. And that actually goes along with the recent recommendation. Single venous event, it may be managed as general population patients if it is clearly provoked. Confirmed APS, several months or years later, tests become negative. Does that have any significance? It may or may not have significance. Depends on what was the problem, the risk factors at the time of the problem, and APL profile. So I didn't answer the question. I understand, but I need more information.
So the question is, patient with Raynaud's, when is scleroderma really scleroderma? And this is an interesting question. It depends on whether you're a doctor taking care of patients or whether you're a doctor setting up for a clinical trial. Clinical trials have criteria that are set up to make a diagnosis of scleroderma. There are 9 points that you have to hit. They include having scleroderma skin changes that are proximal. That's a 9. That means you have the diagnosis. Puffy fingers is a few points. Telangiectasia is a few points. The presence of Raynaud's, the presence of autoantibodies that are scleroderma specific. And then just you add those up, and if you hit a 9, you meet criteria that would make you eligible for a clinical trial. If you're a doctor in practice, I just want to point out quickly before he hits the bong, that there was a study done with Raynaud's patients that came in, and they had a little of this, a little of that. They didn't know whether they had scleroderma or not. And they characterized the patients by whether they had abnormal nail fold capillaries or positive antibodies against scleroderma known autoantigens. If they had no normal capillaries and no autoantibodies, and they followed these patients, only about 2 to 5% developed scleroderma in the long-term follow-up. If they had a positive capillaries or positive antibodies without capillaries, those patients, 25% developed scleroderma within 2 years. If they had both abnormal nail fold capillaries and a positive scleroderma known antibody, 80% developed scleroderma within 2 years. So I would be very suspicious in the Raynaud's patient that has abnormal nail fold capillaries and positive serology associated with scleroderma, that they got the real disease.
So this question is what to do with a isolated positive anti-law antibody without Rho. As you know, that's quite unusual. So the first step would be in my institution, because they only give you a positive or negative, but down in immunology, they know what the titer is if you ask them. I would call and find out whether it was low titer or high titer. A significantly positive anti-low is consistent with Sjogren's or lupus, and certainly is helpful diagnostically, and confers a little bit of risk of neonatal lupus, so I would tell the OB. But it's unusual, but occasionally we see patients who remain law positive, and I think it's just a pathogenic autoantibody that's typical of lupus and Sjogren's.
So at the beginning of my talk, I said I don't know which one is more scary, systemic sclerosis or CAPS. I think we found the right patient. APL nephropathy plus scleroderma renal crisis. Is there a role for sirolimus in the management? I mean, I think I discussed about the sirolimus. We are going to hear more and more about sirolimus with case reports in the future, and I have some data to support that it may have a role. For the scleroderma, I will refer it to the expert.
I'm sorry, what?
In systemic sclerosis, renal crisis, is there a role for mTOR inhibition, like sirolimus?
Oh, yeah. In the scleroderma renal crisis, there would be no role. In fact, these agents used at one point as an antifibrotic strategy, and in those patients with scleroderma, they developed renal insufficiency, and it was sort of a significant percentage of patients, and because of the potential renal toxicity, it's generally avoided, although used in the transplant population and generally tolerated in those patients.
Thank you.
Okay, I can do another one. Yeah. So there's a question about what's the role of rituximab in the treatment of scleroderma, and another question: if you do give it, what do you do with corticosteroid treatment? The role of rituximab is not defined. It does not appear to have a major impact on aggressive skin disease, but as I pointed out in the lecture, it may have a role in reversing active lung disease. And so my use of rituximab is limited to those individuals who have failed myclophenolate or even Cytoxan at low dose, before moving to rituximab. And I use the corticosteroid. I do pre-treat, but I keep it at a 40 milligram dose. I try to keep it under the high dose, and I haven't had any problems thus far.
Dork, you've got to leave in 5 minutes, so why don't you do a couple, and then we'll let Joe go and just go back to you.
Sure. So there is an interesting question here. I'm trying also to organize the questions, but this is about pulmonary hemorrhage. Without catastrophic APS, do we see pulmonary hemorrhage? And what is the treatment? Anticoagulation, immunosuppression, or both? It's rare. I have around 10 to 15 patients with diffuse alveolar hemorrhage. Something interesting is usually they are male with no lupus, and if they are female, lupus or lupus-like disease, and one group presents acutely, responds well to the treatment, but the majority of these patients, they have chronic symptoms. CAT scan shows ground glass, and they usually respond to steroid, and after that they require immunosuppressive agent. I have patients who are not anticoagulated because they do not have history of other thrombosis. And email me if you are interested. We just published a literature review as well as our experience. Usually cyclophosphamide or rituximab-based regimens do better. My treatment algorithm is I start with mycophenolate mofetil, add rituximab quickly, and I have 3 patients on long-term IVIG. Probably they went through over this protocol, and then I decrease the frequency of IVIG over time. There is no predictor of response in these patients. It's a generally difficult to treat situation and generally responds to steroid. That was a long answer, sorry. And in a patient, triple positive had a heart attack, which is the better form to treat? Very good question. Really no good data on the management of MI in APS patients because large series is there in so many MI patients. Probably my choice would be warfarin in a relatively young patient, relatively high-risk APL profile, and no other cardiovascular disease risk factors. Elderly patient, hypertension, hyperlipidemia, the story may change, and I would add aspirin to the management too. Association between infertility and antiphospholipid antibodies. It is really not recommended to check antiphospholipid antibodies in infertility patients, and this recommendation is coming from their association or their organization. However, all the infertility specialists, they check antiphospholipid antibodies, criteria, non-criteria, as well as so many other tests that some of them I never heard. And independent of the result, they do the same thing. If the result is negative, they may give heparin too. Just APL positivity is just a justification. You know, it's a different scenario. There's an emotional component involved, and they basically do whatever they can for the infertility patient. So there is no clear-cut association, but it's checked in the real world. Yeah.
Why don't you catch your breath for a second? Joe can go, and then you can do a couple more if we have.
So
I think we have
comment
time.
on Plaquenil-associated cardiomyopathy. Well, certainly any lupus patient, especially who has been on Plaquenil for a significant length of time and develops a cardiomyopathy, you have to think of the Plaquenil. It's most often seen in small people who've been on big doses for a long time. So the key is that if it's suspected, to do an endomyocardial biopsy, because most endomyocardial biopsies, we were talking about this earlier, don't do any good at all. But that's not true with Plaquenil, because you can find the characteristic little whorls by electron microscopy and rule in or rule out the Plaquenil. So the patients can keep taking the drug if it isn't a myopathy. So if there's reasonable concern, endomyocardial biopsy, and be sure and get EM, because that's what gives you the diagnosis.
Okay, Doric, the cab's waiting, but can you do a couple more answers?
I'll do that. So one of them is, can you comment on the use of dual antiplatelet therapy? I assume aspirin and clopidogrel. There are no studies, but sometimes we do dual treatment. And also, Plavix is something that I sometimes use. You know, there is no strong indication for anticoagulation, but you want to give something more stronger than aspirin. And when we discussed Plavix, I was like, yeah, that can be an option, but no data on that. The rest is actually long patient presentations. Their mitral valve replacement while on Xarelto, triple APL positive, will be on Coumadin, aspirin for life, okay? And would you add hydroxychloroquine? If this patient has lupus, I think I would add hydroxychloroquine. And if we are sure that the mitral valve replacement is because of APL-induced vegetation or thickening? Difficult to know. Probably I would add, but I need more information on that.
Thanks very much.
Sure.
Really, it's been tremendous, and thank you very much for making an extra effort.
So please email me for the rest of the questions. I'm sorry, I need to catch an international flight, but it was great, and congratulations on this great course.
Bye-bye. Bye-bye. Take care. Thanks so much. All right. Have a while. Okay, Fred, you're up.
So what is the meaning of a patient that has a positive SCL70 but no Raynaud's and no other symptoms or signs of scleroderma, including the lack of interstitial lung disease? That's what we would call a false positive test. And the reason I say that is the SCL70 assay was first set up by Immunoblot and now commercially is available by ELISA. And so there's a number of false positives. It's exquisitely sensitive, and you really have to tie that type of situation into the clinical picture. Would I follow the patient? Sure. But I would be comfortable if it was an ELISA that was particularly low titer of being a false positive.
So the question is, does optical coherence tomography differentiate between retinal changes from tamoxifen or Plaquenil? I think the answer to that is no, or macular degeneration, and I'm not sure how the ophthalmologists separate out macular degeneration, but they really can tell the difference between that and Plaquenil toxicity. So with tamoxifen, I believe that there may be some overlap. And then the question is, does the publication overstate the prevalence of Plaquenil toxicity? Well, remember that when I showed you these graphs, these were like 20 years. So after 10 years, then the amount of toxicity really does go up. I think I follow the guidelines well. I think I'm very OCD about following people. Every year I have a patient who gets Plaquenil toxicity. And, I've had lots of patients with Plaquenil. It is a real phenomenon, and I think it's quite hard to avoid it, even if one tries to be very careful about it. So I think those graphs represent my experience.
Is it reversible? Is it always reversible, or is it ever reversible?
Well, when I was a fellow, the textbook said that if you got toxicity from chloroquine, it was irreversible, and if you got toxicity from Plaquenil, it was reversible. I think that the most of the time it does not reverse, and oftentimes it actually continues to progress for a while because of the extensive tissue deposition. So the nice thing about optical coherence tomography is it picks people up before they really know that they have symptoms a lot of times. So even if there's a little progression, the patient's still fine. But I don't think it reverses most of the time.
So this ties into that. That is, what is the role of hydroxychloroquine in the treatment of scleroderma? For scleroderma per se, probably no good evidence that it's helpful. That isn't to say that it might be, but remember that scleroderma is in the family, and we often have patients with overlap. And for patients that have a polyarthritis, hydroxychloroquine may be helpful. And for those that have lupus features, like the mixed connective tissue patients who often have a scleroderma dimension but may also have a lupus dimension, certainly I use Plaquenil.
Okay, so this is a 39-year-old African-American female who wants her first child, had a diagnosis of class 4 nephritis and failed MMF. Eggs were harvested but declined Cytoxan anyway, treated with steroids and Rituxan. Repeat biopsy is mesangial. Patient trying to get pregnant now. Nephrologist wants to give tacrolimus during pregnancy. So a couple comments. First of all, if lupus nephritis arises during pregnancy, this question makes the point that tacrolimus is now the first port of call. It is probably safer than azathioprine. And there's a lot of data that I didn't go into suggesting that tacrolimus can be very effective as an induction agent. The calcineurin inhibitors have a reputation for being, when they're stopped, for having flares more often and not having durable therapeutic, but in pregnancy, you just want to get the patient better. So that's a good idea. Now, then the question is, did the patient really fail? Well, if she went from class 4 to mesangial, then maybe she's not doing so badly. Because if the patient really has active nephritis, then she shouldn't become pregnant. But if the biopsy is mesangial, that suggests that she's doing better. But then you have to ask, well, if she's really mesangial, if you look at the pathology of mesangial nephritis, it's not really attached to the glomerulus. So if there's hematuria and proteinuria, then maybe the biopsy didn't get the class 3. And I talk with my nephrologist about this because in theory, mesangial nephritis shouldn't cause a problem. So you have to ask why the biopsy was done. So assuming the patient's doing fine, there's been substantial resolution of proteinuria, and she doesn't have dysmorphic red cells, and she otherwise looks good, then as a drug to preserve renal function and prevent a flare in a patient who still has an active biopsy, Tacro is not a bad choice. How confident am I, without knowing more about this patient, that she really should be attempting pregnancy? It's a little scary. So I'd like to know that she's otherwise pretty stable and that there's not a lot else going on. That said, the combination of prednisone and Rituxan is not as evidence-based as Tacro. So Tacro is a better therapy, at least in the literature, than prednisone and Rituxan, and would therefore offer some hope of better disease control. Age 39? Well, I mean, you want your patient to have a baby, and it's kind of a last-ditch effort. So I think that these are situations in which the rules that we'd apply to a 23-year-old in terms of really being in remission probably need to be bent a little bit in this case, and you want to figure out a way to allow this to happen. Is that what your question was? Yeah.
So a question was how good is Actemra or talizomide in the treatment of scleroderma? The answer is that the study thus far has been disappointing when you look at skin disease. It was a negative trial that was just completed. There was stability during that trial of the lung function, but the study was not designed to study patients with active lung disease. And so thus far, the only place that I'm using this agent is those individuals that have an overlap of polyarthritis, and in particular, as I mentioned in the lecture, those individuals that have what I call the scleroderma arthritis, which is a different beast with tendinitis and friction rubs. I've had a good experience with them blocking IL-6 pathway. So that's something to consider. Do a couple of them. Practical tips for doing nail fold capillary microscopy. Well, I wish I had my slides here, but you can take immersion oil, put it on the base of the nail where the nail fold capillaries are, and then take your ophthalmoscope, and you can focus and see the nail fold capillaries very good right at the bedside. There is that actually costs about $5, a little tiny scope that you can hook on your cell phone and on the camera, and you put the oil and you put that little scope on, and you can see it on your iPhone very beautifully and take nice pictures. It's very, very nice. And I buy them for the fellows, and then I have my own, which is a $200 scope. But there's a lot of literature looking at nail fold capillaries and making this and that of it. I must say that I don't think much has changed since 1950 when they were first described as a diagnostic tool. But those that do that research suggest that us rheumatologists should have a video camera set up in the office to do it more effectively. I'm happy for those that are interested to send you the link to get that little scope to put on your camera. It's made in Korea. I don't know whether it's north or south, but
Steve, if you have a question, can you come to the microphone?
I nail fold everybody with the ophthalmoscope and get great images, but of course you can't reproduce the great images without the camera. So I went ahead and bought your little device, and I can't get it to work. So then I went ahead and I spent about $1,000 and got one that was too powerful, more than the 2 halogen lights, and I was watching one cell at a time go through. So I have these really cool videos. So then I went back and got the same one that we used at the Philadelphia VA, like in year 1, and I have that, and as soon as I get it set up, that is the only way that anyone will pay you to do it, because you have to document the video of it.
Oh, I see. Well, the fellows of using that little thing that I just told you about, I just, in fact, last week.
I need to know your trick,
Had
because
beautiful pictures.
I've had this device that you're describing. It was actually written about in the clinic's book to get it, so that's where I found it.
Okay.
But I can't get it to take accurate pictures.
I'll send one of my fellows to teach you how to use it.
I'll hold you to that.
Okay, Joe.
All right,
let's
so
keep it moving.
Do you see patients with non-retinal ocular plaquenal toxicity? I mean, there are reports of people who have visual disturbances which are really cortical in nature. When they start Plaquenil, there's been corneal staining, but really not. So it's not a concern that has arisen. Has anybody seen it? Has anybody? Yeah. Ocular myopathy. Okay. Yeah.
The question is how do you differentiate between primary and secondary Raynaud's? And this, again, is the art of medicine. If you're a primary doctor, as opposed to those of us that rheumatologists that usually have a workup that comes with the patient, you could say that if it's a young individual, onset of Raynaud's, usually in the teenage years, that has symmetrical involvement of their digits, maybe involvement of the feet. Interestingly, with a lack of involvement of the thumb, it turns out the thumb is more likely to lean you towards secondary Raynaud's, where the events are annoying but not painful, and they never have an ischemic event, nothing that opens the skin. If they have an opening in the skin, they ain't got primary Raynaud's. You could argue that individual under the age of 20, mild Raynaud's, lack of thumb involvement, and if you want to do your examination and you don't see nail fold capillary abnormalities, that they got primary Raynaud's, and you could follow that patient without any further workup. If you're anxious because they ache or they have a symptom that make you think of a connective tissue disease, then certainly those are patients that getting serology may help. And as I just said earlier, a positive serological test, particularly in the scleroderma family, makes you worry that they're going to transition. But there were studies done in the 70s that looked at these so-called undifferentiated cases that came in with Raynaud's, and a positive ANA of a significant titer increased the risk of developing a rheumatic disease in the realm of 20%, usually within a couple of years after the onset of Raynaud's. If the individual is 40 years old and they come in with Raynaud's, then you better start finding out why, because primary Raynaud's usually doesn't occur, and that it tends to be an inheritable disorder. 30% of primary patients have a relative that also has Raynaud's as well.
Okay, so I saved this question for last, hoping we'd run out of time. So I'll tell you what I know, and then if anybody in the audience knows more about this than I do, I would invite comments. Please comment on the use of cell-bound complement activation products to help diagnose lupus. Well, I guess the cell-bound activation product we know about is C3 fragments seen in the Coombs, but there is research that suggests that primarily C4 degradation products, which lodge on red cells, platelets, T cells, B cells, are highly characteristic of lupus and aid in the diagnosis. And I don't know of anybody who is actually using these in practice. Does anybody have more to add to this? Because there is undoubtedly more information out there. Okay, so they're highly characteristic of lupus, but not as used diagnostically. Okay. I never use it. Okay. Yeah. So that may be part of that. Okay. Yeah.
So the question is, what's the role of a use of octreotide for the treatment of GI motility problems in scleroderma? Back in when I think I was in high school or something, there was a paper written up of 5 patients that had recurrent episodes of pseudo-obstruction, and octreotide was helpful for those patients. And I've used it periodically, less so recently because of other options, but octreotide may improve motility in patients that have episodes of pseudo-obstruction. More effective, in fact, and another question that was asked is antibiotic therapy. And you can pick your antibiotic, but it's I would say in my practice, it's 80% effective, dramatically effective in most. Xifaxan, the one that's not absorbed, is on the market for, quote, irritable bowel syndrome, has been very effective. Again, I use it for the full 14-day course, but I have had patients who have responded in 3 days because the insurance companies usually don't let us get the 14-day course. I have also used Flagyl with good success as a second agent, and I've used amoxicillin and Cipro, also very effective agents, and I've rotated those so that the patient moves from one to the other. Many patients will use antibiotic therapy, get over an acute event of distension and diarrhea and cramps, and then chase that with a probiotic to try to capture a normal, different bacterial flora, and then use what you can to help motility. Generally, if it's a constipation, diarrhea, or cycle, my first treatment is the use of Miralax. Miralax is reasonably safe, used on a start out with a daily dose. Most patients start getting too loose stools with that, and then you move towards a regimen that works for them, whether it's every other day or every 3 days. But if you can stop the constipation cycle, then you'll greatly help the distension diarrhea cycle that follows. If they don't have that, after periods of constipation, they get into a crisis. And so that's usually my approach to the bowel disease. Now we have this new drug, prucalopride, and we've been having a positive experience when I talk to our GI doctors, who, but I'm just starting to use it. And it's usually 1 milligram daily or 2 milligrams daily if they don't tolerate the 1 milligram. It's a fairly gentle drug, but it has good rationale for helping the constipation diarrhea cycle that can happen in these patients. Lindsay and those types of agents I rarely don't use.
That's enough about bowels at almost 5 p.m.
I'm answering like 6 of these questions.
I just wanted to do that to you once. Joe, are you out of questions? Joe's out. Okay. Fred, are you almost out?
Which patients with limited skin disease develop scleroderma? Well, develop interstitial lung disease. It's seen in 20% of patients who have limited disease. So you can't, again, just look at black and white and say, oh, you don't have to worry, you have limited scleroderma, there's no lung disease. And it's, again, remember, it's the composite picture. It's not the black and white, it's the Technicolor approach to patients. So if you have a young African American or Native American patient, particularly if they have antibody to topo, but in addition to U3-RMP or the antibody to U11, U12, or the antibody to THTO, those are patients that tend to have limited skin disease and develop interstitial lung disease. The fact of the matter is that I approach every patient as though they may have interstitial lung disease, do a good exam, and then couple with that, at first visit, a high-resolution CT scan so you have a baseline, and pulmonary function test, and then I follow the pulmonary function test sequentially.
I'm going to suggest that if anyone has a question submitted to Fred that he hasn't answered, that he'd be happy to come to answer it up here. We can call it 5 o'clock. Close enough.
All right. Very good. Thank you all.
Well done, guys. Good, very nicely done. Got through most of the questions. Fantastic. Good stuff. I think you're all